Good afternoon. My name is Kusmirek. I am a radiologist at University of Wisconsin in Madison. I will be talking about thoracic manifestations of connective tissue diseases. I have no disclosures. I will briefly talk about diagnosis and classification of connective tissue diseases, significance of lung involvement, patterns of lung involvement, and common imaging findings. Connective tissue diseases are systemic inflammatory conditions associated with circulating autoantibodies, which result in immune-mediated damage to tissue. The most common antibodies associated with specific diseases are listed in this table. However, we know that the presence of antibodies can only suggest a connective tissue disease, and it's not sufficient for the diagnosis, which is much more complex. Lung involvement may be the presenting feature or develop after the diagnosis of CTD. These are the most commonly seen connective tissue diseases in our practice. However, about 25% of patients fulfill criteria for more than one disease, and this is called overlap syndrome. Mixed connective tissue disease features has features of SLE, scleroderma, and inflammatory myopathy, as well as high titers of R and P antibodies. These findings can occur sequentially. Undifferentiated connective tissue disease presents with clinical and serological manifestations. However, these do not fulfill criteria for any specific existing disorder. Here are criteria for diagnosis of SLE and scleroderma. These include multiple findings on physical exam, laboratory data, including antibodies. All these are assigned at certain points. As you can see, for SLE, pleural and pericardial effusion are included as diagnostic criteria, and for scleroderma, pulmonary hypertension, and interstitial lung disease. That means when we see findings on imaging, we can actually contribute to diagnosis. I want you to look at these 4 images. These are 4 different patients with connective tissue diseases. I want you to look at them and think what pattern is present and what disease you would suspect or suggest as a possibility in these 4 patients. Please look for a moment. You can write down what you think. At some point during this lecture, we come back to these images. Okay. So patterns of interstitial lung disease in CTD are not that easy because one disease can have different pattern in different patients. Also, the pattern may change or the patterns may coexist in the same patient. Overall, when you look at this table, NSAP is the most common pattern in connective tissue diseases, with the exception of rheumatoid arthritis, when UIP is the most common pattern. In PMDM, OP is also very common. Also note that overall, ILD is most common in scleroderma and PMDM. It's not common in lupus. To make things even more complex, there are multiple other manifestations in the chest that we can encounter. Acute manifestations include pneumonitis, diffuse alveolar hemorrhage, diffuse alveolar damage. There may be airway involvement, both small and large airways. Serositis is very common. We may see mediastinal lymphadenopathy or thymic enlargement. Cardiovascular findings include myocardial fibrosis, pulmonary arterial hypertension, vasculitis, thrombosis. Accelerated atherosclerosis is a big problem in connective tissue diseases. Additionally, we can see complications either related to immune response in these patients. These patients are prone to infections, malignancy, especially lymphoma. But some of these complications may be related to therapy. We can see drug-induced lung injury. We can see infections related to immunosuppression. And again, we can see malignancy related to immunosuppression. Let's look at these 3 patients who are seeing biorheumatologists. And let's think what features are present on these 3 scans and what would you tell the referring clinician? What do you think is the diagnosis? And again, we come back to this later. Let's talk first about rheumatoid arthritis. This is the most common connective tissue disease, affecting about 1% of the population worldwide. CT abnormalities are seen in 50 to 70% of patients, and pulmonary involvement is responsible for 10 to 20% of mortality. Rheumatoid arthritis can affect the lung parenchyma, airways, and pleura. Airway involvement may be the first manifestation. Clinically significant interstitial lung disease is seen in 10% of patients, most commonly UIP pattern, and this carries poor prognosis. In this patient, we see traction bronchiectasis, reticulation, architectural distortion, and honeycombing, or all peripheral A and basal predominant. Airway involvement can manifest as bronchiectasis, constrictive bronchiolitis, and follicular bronchiolitis. Patients may have necrobiotic nodules. These nodules can grow. They may also regress with therapy. In this patient, the nodules were growing, therefore biopsy was performed, and this was confirmed to be related to the patient's known rheumatoid arthritis. SLE. Pleural disease is the most common thoracic manifestations. Here we see bilateral pleural effusions and pericardial effusion, which happen in up to 35% of patients. Additional cardiovascular findings that we can see in these patients include findings suggestive of pulmonary hypertension, venous or arterial thrombosis, vasculitis, as well as rarely Liebman-Sachs endocarditis. Acute pneumonitis affects up to 14% of SLE patients. Mortality is very high, up to 50%. In this patient, we see multifocal ground glass opacities, patchy consolidations. Differential would include also hemorrhage. Other lung findings in SLE include interstitial lung disease, again, most often NSRP, and shrinking lung syndrome. This is a patient with SLE and known interstitial lung disease. The bottom row is her baseline scan. She presented with acute shortness of breath, and bronchoscopy confirmed the presence of diffuse alveolar hemorrhage. We see multifocal bilateral consolidative and ground glass opacities in this patient. ILD is the most common chest manifestation in systemic sclerosis and accounts for 33% of mortality. All patients diagnosed with systemic sclerosis should be screened with a CT at the time of diagnosis for the presence of interstitial lung disease and for the extent of the disease. This affects the prognosis and the treatment. The most simple thing you can do is to assess if there is more or less than 20% of involvement of the lung parenchyma. This, along with pulmonary function tests, will help rheumatologists to put the patient in a certain category for risk of development significant mortality. related to interstitial lung disease. In this patient, we see less than 20% of lung involvement and NSIP pattern. And that's also important because patients most often will have an SIP pattern. However, they may also have UIP pattern, which carries much worse prognosis compared to NSIP. Let's look at this patient. She was followed for years for her NSIP pattern interstitial lung disease related to scleroderma. Initially, we see very mild reticular peripheral opacities that progresses over years. There is more glass opacities. This patient also has significant esophageal dysfunction and dilatations on all these scans. Esophageal involvement can be seen in up to 97% of patients with scleroderma. This can lead to recurrent aspiration and worsening of fibrosis. So all these patients are on prophylaxis with PPIs. This is another patient with scleroderma. We see NSIP pattern of lung fibrosis. Also, dilatation of the main pulmonary artery, enlargement of the right ventricle and right atrium. So this patient most likely has pulmonary arterial hypertension, which is responsible for 28% of scleroderma-associated mortality. ILD, interstitial lung disease, is usually present at the diagnosis or develops early during the disease. Often this may stabilize with time. However, pulmonary arterial hypertension is the late finding. It happens later during the disease, creates very poor prognosis, and it's important to report findings that suggest this. It is more common in limited disease and affects up to 50% of patients with CREST syndrome. Survival is poor, 52%. Other cardiac complications include myocardial fibrosis, pericarditis, and pericardial effusion, which is often asymptomatic. These in the images show a patient with small pericardial effusion and findings suggestive of very severe pulmonary hypertension. This is another case of a patient who was evaluated for a different indication, and incidentally, this finding was noted. So hopefully you all noted that there is diffuse thickening of the aorta, including ascending, descending, and the arch. The patient had Sjogren syndrome, and eventually this was diagnosed as vasculitis related to Sjogren syndrome. I'm assuming this was secondary because large vessel vasculitis is very uncommon in connective tissue diseases. Sometimes can be seen in RA, has been reported in SLE. Small vessel vasculitis is more common, especially in SLE, RA, and sometimes in Sjogren syndrome. This is a more common presentation of a patient with Sjogren syndrome. We see diffuse cysts. Most of them look perivascular. Some of these patients may also have ground glass opacities, a little bit of ground glass and reticular opacities in this patient. Sjogren syndrome is the second most common autoimmune disorder after rheumatoid arthritis, and the pattern of lung involvement can vary, but most commonly is LIP and SNIP. This is another patient with Sjogren syndrome. We see findings consistent with LIP, but also small calcified nodules. This was a biopsy-confirmed amyloidosis. The other thing that we have to remember is that patients with Sjogren syndrome are at risk for developing lymphoma and should be monitored for that. Extensive consolidations, peribronchial, organizing pneumonia pattern in a patient with polymyositis. Again, OP and NSIP are the most common patterns in patients with polymyositis and dermatomyositis. The lung issues can be exacerbated by the fact that these patients aspirate and there is hyperventilation related to muscle weakness. If we see a patient with rapidly progressing interstitial lung disease and the patient has PMDM, we should think about antisynthetase syndrome. Interstitial lung disease may be the first presenting symptom, and it progresses rapidly. The prognosis is very poor. This is a patient with extensive soft tissue calcifications, already proximal upper extremities, and chest and upper abdominal wall. These were consistent with calcifications in dermatomyositis. Let's look at this table. This table shows overall in lung and airways pleural involvement, as well as pulmonary hypertension frequency in connective tissue diseases. Note that rheumatoid arthritis can affect pretty much everything. Interstitial lung disease overall is most common in scleroderma and PMDM, and pulmonary hypertension is most common in scleroderma. So let's go back to these images. Hopefully after this review, and maybe even before, you said something like that. UIP pattern in this patient, which is most common in rheumatoid arthritis. There is also airway involvement, most likely. This patient has LIP, so there is a good chance that the patient has Sjogren's syndrome. OP pattern is commonly seen in polymyositis, and NSIP pattern as seen here with peripheral ground glass reticular opacities, as well as traction bronchiectasis and abnormal esophagus. All that suggests scleroderma. This is a patient with non-scleroderma interstitial lung disease who has quite extensive involvement and NSIP pattern, presented for a 1-year follow-up. And I saw this mass that was not present previously. It's hard to believe. It was hard to believe for me that this was malignancy due to this rapid development. I noted that the patient also has pericardial effusion and small pleural effusion. PET was positive, biopsy confirmed lung cancer. Another thing that we have to be careful about is drug-induced lung injury. Classically, methotrexate was responsible for lung injury in patients in rheumatoid arthritis. In these patients, we see reticular and ground glass opacities that developed after initiation of therapy. Now we have much more common issues related to drug-induced lung injury due to introduction of newer therapies. For example, in patients with TNF antagonist therapy, we can see nodularity, circuit-like reaction related to therapy. This is one more entity that I wanted to mention. This was a patient who presented with OP pattern and had positive autoantibodies, but did not fulfill criteria for any connective tissue disease. So this patient was diagnosed with interstitial pneumonia with autoimmune features. Some of these patients eventually develop connective tissue disease. Let's go back to our cases. So I think we can help our rheumatologists, telling them that this patient looks like may have SLE. This patient probably has advanced scleroderma with esophageal involvement. And this patient with antiphospholipid syndrome may have diffuse pulmonary hemorrhage because most common thoracic manifestations in antiphospholipid syndrome is diffuse alveolar hemorrhage and emboli. Manifestations are seen in the abdomen. Patients have cutaneous and cerebral manifestations as well. This can be isolated syndrome or associated with SLE. And for this appearance, obviously, there is differential that includes not only diffuse pulmonary hemorrhage, but pneumonitis, infection, Important points. In patients with connective tissue diseases, chest abnormalities are common. Lung involvement can be present at diagnosis or can develop later. It leads to substantial morbidity and mortality. The presence of interstitial lung disease and pulmonary hypertension often determines patient's prognosis. Thank you for your attention.